We'll just give it a couple more minutes to see if anybody else will join us. Good morning, everyone. We're just waiting another minute or so to see if there'll be anybody else joining us. Good morning, everyone. We've still got a few more people joining us, so we'll just wait another minute or so. Good morning, everyone. Hello and welcome to this MICRA Webinar on inequalities in aging and health disadvantages amongst ethnic minority groups. Sorry, we'll just pause a little bit there while we wait for a few more people who are joining us. Okay, so my name is Tirani Chandola. I'm a professor of medical sociology, and I'm one of the deputy directors of MICRA. MICRA is the Manchester Institute for Collaborative Research on Aging. Today's MICRA webinar is about ethnicity in the COVID-19 pandemic, and where, because it's MICRA, we have a particular focus on older adults. As many of you already know, the COVID-19 pandemic has had a disproportionate impact on most ethnic minority groups in England. But this inequality is a crisis within a crisis. The pandemic has laid bare and exacerbated existing deep-rooted inequalities. In this seminar, I'm very pleased that we have Dr. Ruth Watkinson and Dr. Alex Turner, who will be discussing their recent study looking at ethnic inequalities amongst older adults, and they'll be outlining policy changes that are necessary to build back fairer following the COVID-19 pandemic. They will be joined by myself, and I'll be speaking later on about ethnicity and the COVID-19 vaccine rollout in the UK, and I'll be looking at some of the reasons for why there is this hesitancy among some ethnic minority groups. So welcome, everyone. First of all, we will have Dr. Ruth Watkinson and Dr. Alex Turner presenting, and they'll be talking about their recent study, which has used the National GP Patient Survey to describe ethnic health inequalities amongst older adults. And this is amongst the age group who are 55 and over, and that's an age group that's becoming increasingly ethnically diverse. And this is a very large GP patient survey, so over 150,000 older adults who identified as belonging to one of the ethnic minority groups, as well as over 1 million white British adults as well. So just a little bit of background about our speakers today. Dr. Ruth Watkinson is a research associate at the Center for Primary Care at the University of Manchester. She had a background in biochemistry and did a PhD at the University of Cambridge, and she had been working biomedical research for many years. And later on, she moved on to public health. She did an MSc in public health at the London School of Hygiene, and before she came back to the University of Manchester. So a lot of her research is on health inequalities and looking particularly at inequalities between ethnic groups and socioeconomic groups. Dr. Alex Turner is an honorary research fellow in health economics and at the University of Manchester, and he's also an associate director at RTI Health Solutions. A lot of his research is on health inequalities, but he has a lot of research interests on the development and application of methods to evaluate the effects of interventions and exposures using observational data. So welcome, Ruth and Alex. Whenever you're ready, please do start sharing your slides and presenting. For the audience, please submit your questions to the chat box, and we'll be taking your questions at the end of both our talks today. But if there are any urgent questions, please do message using the chat box. Well, I'll try to address them as the speakers go on. Also, if you could identify yourself in the chat box and whether the question is for a specific speaker or for the whole panel, that would be great. So thank you, Ruth and Alex.
Thanks, Tarani. Thanks for the introduction. So yes, I'm going to be sharing some of the work that we've done recently looking at health inequalities between ethnic groups amongst the older adult population in England. And this is work that I've done in collaboration with Alex Turner and Matt Sutton. So just by way of a really brief introduction, I'm sure everyone here is aware that England has an ageing population. And as Tarani mentioned, the ethnic diversity of the older adult population is increasing. And this is largely as a result of historic migration patterns as well as current migration. So in terms of what we know about health outcomes and health inequalities between ethnic groups, for almost all of the ethnic minority groups in England, estimates of life expectancy and healthy life expectancy are substantially lower than for the white British majority group. In general, it seems that inequalities tend to be wider for women. And it's also been shown that inequalities between ethnic groups tend to increase with age. So of course, it is particularly important to look at these inequalities amongst the older adult population. So it's not entirely clear why this happens, but from what we do know, it's clear that this is not kind of a generational effect. It's not that these issues are going away for younger age groups. It's just that as each generation ages, these inequalities open up. So life course perspectives suggest that this is likely due to the disadvantages that arise from structural, institutional, and interpersonal forms of racism tend to be repeated across an individual's life course. And these disadvantages gradually compound so that as each person ages, this leads to gradually worsening health outcomes. So that's a very brief overview of some of the things that we do know about health inequalities between ethnic groups. But there's actually a lot of limitations of existing information. And I think to some extent, the shock and the kind of public surprise at the extent of the inequalities that have been laid bare by the COVID pandemic really comes from the fact that there hasn't been enough attention and there hasn't been enough research or monitoring or understanding of these health inequalities between ethnic groups that of course did predate the pandemic. It's merely that the pandemic has brought this to the fore. So to some extent, this stems from the fact that there's a lack of data in a lot of ways. So there's relatively poor recording of ethnicity across a lot of administrative data sets that are kind of routinely used to keep a track of health trends and differences in health outcomes between groups. So as well as in the kind of routine and administrative data, some of the big national data sets that we rely on to understand the health of people in England tend not to include enough people from ethnic minority backgrounds to be able to do any meaningful analysis. So because the older generation also has the least ethnic diversity, it means that older people from ethnic minority backgrounds are really particularly excluded from research, and health inequalities affecting them tend to be kind of missed and overlooked. So again, kind of stemming from the same problem of not having enough people included in data sets or with their outcomes recorded, where analysis is done, it means that specific ethnic groups are often kind of combined into these broader categories in order to do the analysis. So it means that sometimes it's groupings that are fairly broad, such as Asian, but even the catch-all term BAME. And of course, comparing the white British group to all people from ethnic minority backgrounds really masks that wide diversity of experiences that can affect different groups to a different extent. So it risks kind of masking a lot of the health inequalities. So as well as this kind of lack of attention on describing and monitoring and keeping track of health inequalities so that we can do something about it, there's also been a lack of exploration of what's driving these inequalities. So over the past couple of decades, there's been a kind of positive shift away from looking to kind of genetic or cultural and behavioural explanations for inequalities in health between ethnic groups. But there's been relatively little exploration of what is driving these differences. So at a kind of very big picture level, of course, we could say, well racism is likely the cause of these issues. But if we want to make policy that will really address this and really make change, we need to understand the pathways that connect ethnicity and racism to poorer health. So we set out doing this project to try and fill some of these gaps. And Alex is going to talk about work looking at the determinants of health and kind of policy implications, and he'll speak about that in a moment. But I'm going to talk about our first aim, which was to estimate ethnic inequalities in health for the older adult population in England. So using age 55 plus as our kind of definition of older adults. And as Tarani mentioned in the introduction, we were using the General Practice Patient Survey, or GPPS dataset. And we wanted to use the most recent years that we could, so it's 2015 to 2017. So we wanted to use this survey partly because it's really large. There's over 2 million people that respond to it each year. And it's nationally representative, so it should allow good estimation of true inequalities in the population. It also asks questions about several health measures. So the first one that we're interested in is health-related quality of life, which I'll explain a little more about in a moment, and long-term health conditions that people reported. So just a kind of brief introduction to who was in the sample. So this is people responding to the GPPS survey. We had over 1.39 million people who were in the age 55 plus categories. This is a really big sample. And you can see from the chart in blue, the majority of respondents are in the kind of younger, old age groups, but there was about 30% who were age 75 and over. There was also a slight skew towards female respondents, but this was weighted for an analysis, so it is representative of the underlying population. In terms of ethnicity, as you'd expect for the kind of older adult population, a large majority identified as being white British ethnicity, so almost 90%. And in terms of which ethnic minority groups were most represented, the largest ethnic minority group was any other white, about 2.5%, followed by Indian at about 1.8%. At the other end, the smallest ethnic group was the Gypsy or Irish traveller group, where we had just over 200 respondents. So coming into the results for our first outcome then, inequalities in health-related quality of life. So health-related quality of life is kind of a quite holistic measure of people's day-to-day overall health. So the tool used in the GPPS is this EQ5D5L tool, which has been quite widely used and has been validated across international contexts. And it's a simple 5-question survey that asks about people's state of their health across 5 different domains. So these domains are very much everyday things like mobility issues, so issues in walking about, problems getting washed or dressed, any difficulties carrying out your usual activities, so that could be work or housework or looking after the family, any pain or discomfort, and anxiety or depression. So across these 5 domains, it asks about difficulties across 5 levels, so from no problems at all to really extreme problems. And so these answers are combined together to make a composite single index, which then gives you a value from 1 to negative 0.594, and that's kind of a summary measure of overall health. So the mean health-related quality of life in this study population, so our older adult group, was 0.75, so relatively good health. So then looking at associations between ethnicity and health-related quality of life, this is showing results from a linear regression model, and this is age adjusted, so adjusted by the age of each individual. So looking at the chart, the reference group, so the baseline category, is the white British group, so they're sitting on the 0 line, and anything to the left-hand side of that is reflecting worse health-related quality of life than the white British group, with things to the right of the 0 reflecting better health-related quality of life. So just looking at the overall trends, you can see that for very much the majority of ethnic minority groups, there was worse health-related quality of life, either for men or for women or for both genders. In terms of the worst outcomes, we saw that the widest inequalities occurred for the Gypsy or Irish traveller, Pakistani, Bangladeshi and Arab groups. And just to kind of benchmark the extent of the inequalities that you can see in this chart, the difference between those groups and the white British group was similar to, or in a number of cases actually greater than, the difference associated with a 20-year increase in age. So particularly thinking about the older adult population, these are really meaningful differences in health. If you think about the difference in health between a typical 60-year-old and an 80-year-old, that's really going to affect people's lives. So consistent with other reports, as I said in the introduction, we saw that inequalities did tend to be wider for women, but that didn't apply to all ethnic minority groups. And I think it's also worth highlighting that we saw really quite a lot of variation within some of the ethnic kind of meta groups. So for example, if you look at the Asian ethnic minority groups, there are some groups who had relatively better health-related quality of life than the white British group, some with similar health, but also in the Bangladeshi and Pakistani groups who had amongst the worst health outcomes of all ethnic minority groups. So you can just see the importance of doing analysis where you're able to look at each group individually, because if we put all those groups together, you risk masking some of that inequality. So the second health outcome that we looked at was inequalities in the number of reported long-term health conditions per patient. So again, I'm showing you results from a regression model, this time a negative binomial regression model for the count of long-term conditions. So here, anything above 1, where the white British group sits, reflects more long-term conditions per patient. So we see relatively similar trends here, with almost all ethnic minority groups having either as many or more long-term conditions than the white British group. The exceptions to this, though, were for Black African men and for Chinese men and women, where there are relatively fewer conditions. In line with the health-related quality of life results, the worst outcomes again were for the Gypsy or Irish traveller, Pakistani, Bangladeshi and Arab groups. Although this time, in contrast to the results for health-related quality of life, there was relatively smaller differences between genders here. So then just to sum up what I've told you, we estimated ethnic inequalities in health-related quality of life and in long-term health conditions amongst older adults in England using a large national survey. We found that most, but not all, ethnic minority groups had poorer health-related quality of life and as many or more long-term health conditions than the white British group. We saw the widest inequalities occurred for the Gypsy or Irish traveller, Pakistani, Bangladeshi and Arab groups, with differences here similar to 20-year increases in age. I think importantly as well, this is actually the first nationally representative analysis of ethnic health inequalities to include the Gypsy or Irish traveller or Arab ethnic groups. And I guess it's particularly important because their outcomes were amongst the worst. We also found that overall inequalities did tend to be wider for women as compared to men. And again, I just want to highlight that heterogeneity that we were seeing within metagroups, just again to emphasise the importance of not collapsing ethnicity data into broader categories. So I'm going to leave it there, and then Alex is going to pick up on some of the work we did to try and understand what's driving these inequalities and what might be done about them. But I just want to say thank you to Dr. Alex Turner and Professor Matt Sutton. It was brilliant working with them, and to a number of other people who have been really supportive and had great input along the project. And thanks for your attention.
Hi, also, hopefully you all can see that. So yes, so thank you very much to Ruth for a great presentation. As Ruth alluded to, this is part 2 of a single study. So Ruth documented quite considerable inequalities in health by ethnicity. But what are the underlying causes of this inequality, and perhaps more importantly, what can policymakers do to try and address them? So in this talk, I'm going to examine some of the determinants of health and whether inequalities in these determinants could contribute to the health inequalities that Ruth has just documented. So before I do that, I just want to give you a kind of a brief overview of what determinants of health are. So I think this Dahlgren-Whitehead rainbow model is a great way of describing this. So it shows how health is determined by lots of things. So this includes what you might call kind of typical determinants of health, such as age or genetics, hereditary factors, and also those kind of behavioural or lifestyle factors, such as cigarette and alcohol consumption. But this also includes what we tend to call social determinants. So these are the socioeconomic and environmental factors which have been shown to predict health, such as community networks, living and working conditions, and also the healthcare services that you receive. So, of course, we're talking about ethnicity here, and of course, inequalities in all of these health determinants and health itself could be driven by racism, and racism of different forms. So this could be institutional racism, interpersonal racism, and also that kind of structural underlying racism. Of course, although this data resource is great, it doesn't allow us to examine all of the factors. What it does allow us to do is examine a subset. So what I'm going to do is going to present some results on a subset of these factors, and then as I go, try and briefly introduce what policymakers might try and do to try and address inequalities in this area. So let's begin with kind of healthcare and wider public services. So obviously this is a large contributor to the production of health in the UK, and luckily the GPPS allowed us to measure multiple indicators of this. So first, we use an indicator for an individual's overall experience of their GP surgery as a marker of quality of care that they receive. We also had information on whether patients reported feeling that there was sufficient or insufficient support from wider local services in order to manage their long-term health conditions. So as Ruth showed, ethnic minority groups have a higher prevalence of a lot of long-term conditions. So this type of support is going to be really important in helping them keep healthy. And then linked to that, we had a question on whether patients felt confident or whether they had low confidence in managing their health conditions. Again, given the higher prevalence in ethnic minority groups, this is very important. So what did we find? So first, we looked at whether individuals reported poor experiences of their GP surgery, of primary care services. So these results were estimated using a logistic regression. So we're looking at the odds of reporting poor health experiences. So values greater than 1 indicate an increased likelihood of reporting poor experiences, and less than 1 a reduced likelihood. So what we found was that compared to the white British group, nearly half of ethnic minorities reported an increased likelihood of poor experiences at their GP surgery. And this was consistent both for the sample as a whole and individually for men and women. So similar to what Ruth documented, the widest inequalities were found for Pakistani and Bangladeshi men and women, where there was almost like a 2- or 3-fold increase in odds of reporting poor experiences. And here, inequalities were mostly consistent across genders. So moving on to these kind of the wider support from local services, we found quite large impacts here. So actually, instead of just a subset of ethnic minorities, compared to the white British group, we found that almost all ethnic minority groups reported insufficient support from local services in managing their long-term health conditions. Here we found that the widest inequalities, we found wide inequalities even for groups where Ruth documented no health-related quality of life disadvantage. For example, Black African men, there was no health-related quality of life disadvantage, but we find here that there is a greater likelihood of reporting poor experiences, so almost a 2- or 3-fold increase for that group compared to the white British. So given that result, it's probably not unsurprising that ethnic minority groups report more likely to report low self-confidence in managing their health conditions. So again, compared to the white British group, the odds of low self-confidence in managing their health was much higher. In this case, the inequalities tended to be much wider for women. So if you look at the Pakistani and Bangladeshi groups here, the odds were much greater for females than for males. And actually, consistent with the health-related quality of life results that Ruth presented, we found that the inequalities in self-confidence in managing their health were widest for Gypsy and Irish traveller groups and for the Pakistani and Bangladeshi groups. So this is indicating that this might be an important driver of health disadvantages. So given this evidence, what can policymakers do about this? So we're finding that there's ethnic inequalities in health services and also wider public sector services. This may be indicative of institutional racism within the NHS and public services. So NHS in particular was founded on the principles of equity. So that means that you should have equal access for equal need. What that means in practice is that for individuals with the same health status, the availability of healthcare services and also the quality of those services should be identical for those individuals. But our results are pointing to this equity not being achieved, and that ethnic minorities may be being failed by the NHS and wider public services. So how can we go about solving that issue? So a key issue, I think, and we think, is that we need to remove barriers to access that might be faced by ethnic minority groups. This might include ensuring that services are more culturally and linguistically competent. So, for example, offering translation services that might, and particularly for individuals that English is not their first language, those translation services may encourage individuals to seek care, but also break down any possible inequalities caused by a lack of communication between doctors and their patients. Also, in the UK now, there's an increased attention to moving towards what we call patient-centred approaches to healthcare, particularly in older adults. At the minute, we maybe have a one-size-fits-all approach. Clearly, this one-size-fits-all approach isn't working equally across all ethnic minority groups, with ethnic minority groups more likely to report that their services are not helping them improve their long-term conditions. So I think what is needed is an exploration of tailoring this patient-centred care approach so that it might differ and be sensitive to the different needs of ethnic minority groups. So moving on to what we typically call social determinants of health. What we're looking, we would like to measure these types of things at an individual level, but that wasn't available in the GPPS data set. But what we did have is a great neighbourhood level measure of social determinants called the Index of Multiple Deprivation. So that measures multiple aspects of deprivation at a small neighbourhood level containing around 1,500 individuals. What's great about this measure is it allows us to combine information from multiple important social determinants of health. So that includes things like education, income, employment, and also kind of housing factors, and also those wider environmental factors we were talking about, like air quality. So what did we find here? So what we examined here was looking at the impact on the likelihood of being in the most deprived quintile of deprivation. So what we found is, compared to the white British group, all ethnic minority groups reported a higher likelihood of living in the most deprived quintile. So ethnic minority groups are much more likely to live in deprived areas. Perhaps importantly here is that the inequalities in deprivation did not necessarily map closely to the patterns of health-related quality of life disadvantage, and we're going to return to that point a bit later. And just to reiterate that point, Bangladeshi and Black African men were very similar here in terms of the likelihood of being in more deprived areas, but they had very different health-related quality of life disadvantages relative to the white British group. So what can policymakers do about this? So underlying inequalities in socio-economic status is an indicator of wider structural racism. But what this also indicates is that health inequalities across ethnic minority groups is not just an NHS problem. So what we found is that health inequalities might be being generated by factors that are not necessarily under the NHS's control. It's not just healthcare. So what this indicates is that collaboration across the whole public sector is needed to try and address ethnic inequalities in health. There's been some great reports recently that have kind of outlined actionable policies to narrow gaps in some of these social determinants of health, in particular things like employment opportunities. So, for example, employers could be encouraged to publish ethnicity wage gaps. So there's a big push now for gender wage gaps to be published by employers, but there's no reason why employers couldn't publish ethnicity wage gaps too. And that actually, one of my current employers is moving towards publishing those ethnicity wage gaps. One other possibility is prohibiting all white candidate lists to ensure that there's sufficient diversity on candidate lists for different types of jobs. What's important to note here that addressing social inequalities is not a panacea. Just addressing social inequalities is not going to solve health inequalities. As we showed before, inequalities in socioeconomic status doesn't necessarily map closely to the health-related quality of life disadvantages. So it is important to address this, but there's obviously other things contributing to health inequalities, and it's important to address those too. So we've examined inequalities in a range of health determinants here, but there's a lot we don't know. Clearly, there's a lot of determinants of health, and there's a lot of mechanisms that are left to test. And this is really important to understanding the mechanisms generating health inequalities, and therefore what policy levers can be pulled to try and address them. Well, importantly, more research is needed to understand when in the life course inequalities emerge. So we document inequalities for older adults here, but it's important to know whether these disadvantages are just emerging in later life, or whether these disadvantages emerge much earlier in life and then just happen to persist into later life. And that's really important to know in what policy levers to pull. I think Ruth touched on this earlier, but a lot of this lack of knowledge is driven by a lack of data on ethnic minorities. The ethnicity is poorly recorded in health records, and that means that researchers who use administrative database for research don't necessarily examine inequalities by ethnicity, and that's not because we don't want to, it's just that the data means that we can't. And also there's poor representation or small numbers of individuals in typical kind of longitudinal research data sets, so that also prohibits research on these groups. So what can policymakers do to improve this? So we think there's a big push is needed to try and improve data on ethnic minority groups. So we are one of the first to document ethnic health inequalities on such a large scale, but we feel like it shouldn't be this difficult. There should be multiple sources of data and maybe higher quality data that should be able to document this, but it just isn't there at the moment. It's important to note that if you can't detect a problem, that you can't address the problem. If there's not data that draws policymakers' attentions to a problem, there's no incentive there to try and to improve that problem. So I think what's also important is that data is needed to hold governments to account on the promises that they make to reduce inequalities. So in the last couple of government mandates to the NHS, reducing inequalities by socioeconomic status, by ethnicity, is front and centre in those aims. But there's not the data there to be able to track the effectiveness of any policies that they introduce and hold them to account on addressing these inequalities. Importantly, a lot of progress has been made on tracking inequalities by socioeconomic status over time. So there's a range of national outcomes data sets that are used to track government policy and local policy, and many indicators on socioeconomic inequalities are now featured in there. But we think that a similar push is needed to try and improve the tracking of inequalities by ethnicity and have indicators of those in national outcomes frameworks. Also, what Ruth touched upon earlier and what we found in the determinants research was that there was variation in the experience of different ethnic groups. So there can't really be a one-size-fits-all approach to try and reduce health inequalities. Ethnic health inequalities, clearly different things are going to work for different ethnic groups, and it's key to try and test these approaches and see what works for different groups. So overall, I'm going to start with the bad things and then hopefully some hopeful things at the end. So obviously we've documented large inequalities by ethnicity amongst older adults. As we've touched upon, this is sometimes equivalent to a 20-year difference in age. So these are pretty drastic differences. There's also evidence that this is partly driven by inequalities in access to good quality healthcare and also good quality support from local services in managing their conditions. And also it's likely to be at least partially driven by differences in socioeconomic opportunities, but socioeconomic opportunities is not the is not the be all and end all. There's other things that are contributing to these inequalities. Note here that this study was conducted prior to the COVID-19 pandemic. As we all know, COVID-19 has impacted ethnic minority groups particularly hard. And if we were to redo this research right now, it's likely that the impacts that we see have been exacerbated. But hopefully, to end on some hopeful things, these things are bad. These differences are large and bad, but these are things that good policy can address. So we just need to encourage policymakers to pull these policy levers to try and reduce these health inequalities. Unfortunately, the Sewell report has kind of made us take a step back. It suggests the system is no longer rigged against ethnic minority groups, but our research is showing that provides evidence that it is rigged against ethnic minority groups, and action is really needed to try and address these health inequalities. So I just want to reiterate what Ruth says. I want to thank our co-authors and also Steph Gillibrand and James Nasri for providing comments on our work, and also for the wider Jumper team for their funding. And we've also got a link to our published study here. So if you want to learn a little bit more, then please do look at that too. So thank you very much.
That's great. Thank you very much, Ruth and Alex. These slides will be made available to all the participants after the talk. I can see from the chat quite a few questions are coming in, but if it's okay, we'll take questions at the end of the second presentation. So I'm going to be the speaker for the second presentation, so I'm going to start sharing my slides now. And this second presentation is about the vaccine rollout, the COVID-19 vaccine rollout, and ethnic differences in that. So my name is Tarani Chandola. As I said earlier, I'm a deputy director of MICRA. And one of the reasons I became interested in this topic about vaccine hesitancy was earlier this year in January and February, a lot of data was coming out and a lot of news reporting about how Black, Asian, minority ethnic groups were far less likely to take the coronavirus vaccine if they were offered it. And that was occurring both in the UK as well as in the US. So a lot of worry about the impact of COVID-19 on ethnic minority groups, especially if they weren't taking up the vaccines. And this led to a subsequent set of news headlines around exploring why ethnic minorities were less likely to take up the COVID-19 vaccine, relating that to issues related to trust, distrust in vaccines, distrust in medicine per se, and a history of racism. So I looked at the most up-to-date data from sort of the most valid sources of data. So Open Safely is a very large data set that looks at GP records. Of nearly a large proportion of people living in the UK, and here we can see here the vaccination rates by broad ethnic groups. So unfortunately, I've sort of characterized it by 5 or 6 broad ethnic groups, and not the very detailed ones that Ruth presented. But the Open Safely data, because it's got millions and millions of people in it, you can disaggregate it down to even smaller, more detailed ethnic groups. And here I've taken what the latest data available for those aged 60 to 64, 65 to 69, 70 to 79, and 80 plus or so. And we see here the differences in the vaccination rates between, say, the Black communities in blue here, and in the brown here, we see it for the white communities. And initially, we see this very large gap between the Black communities and the white communities. So the vaccine rollout was really taking off in January, and so that initial January to February period, we see well over 40% difference in the take-up of the vaccine. But by early April, that 40% gap between the Black and white communities reduces to about 25%. And we see that reduction occurring for the 70, 79-year-olds, and also even, we're hoping that as the vaccine rollout continues in younger age groups, this sort of initial gap, very, very worrying gap in the vaccine take-up gets reduced. Still, as you can see, for the 80-plus-year-olds, most of them have, over nearly 100% of them have been vaccinated. We still see this very large worrying gap. So, 25% gap between the Black communities and the white communities. Here, I'd like to draw your attention to the purple line, the unknown people of unknown ethnicity, and amongst the 80-year-olds plus living in I think this is data for England only, they're largely of white ethnicity. There are very few ethnic minorities who are age 80 plus or so. So so this purple line, you can see here, the unknown ethnicity, which comprises 30% of this population. So once you take that into account, that gap, the 25% gap that we're seeing here is not likely to be quite so large. It's likely to be a little bit smaller. But still, I mean, it's still worrying that we see this large gap. For the South Asian populations here in red, we see some elements of catching up as time goes on. But here again, as Ruth was documenting, there are large variations between the Indian, Pakistani and Bangladeshi communities. So the Bangladeshi communities display more reluctance to take up the vaccine. There was an editorial in the British Medical Journal a few months ago about why is there this apparent vaccine hesitancy among some ethnic minority groups. So they detailed some reasons related to misinformation about the vaccines, worries about side effects and long-term effects on health, potential reasons about lack of trust in vaccines, maybe stemming from a lot of underrepresentation of ethnic minorities in health research and vaccine trials. And then they listed a lot of reasons related to systemic racism and discrimination, like residential segregation, problems of access to vaccine centers, or even to the vaccines themselves, historical mistrust of government and public health bodies, and negative experiences within culturally insensitive healthcare systems, so a lot of which that Alex was documenting. For my next few slides, I'll just be concentrating only on the first three topics, because as Alex was hinting, data on the systemic racism and discrimination, especially at an individual level, is quite hard to get at. So it's not going to be a complete story, but a little bit of a story relating to what extent there are ethnic differences in the first three reasons. And for that, I used the Understanding Society COVID-19 survey. So this is a monthly survey that's been occurring nearly every month since April 2020. And the sample size is quite large for a survey, about 15 to 20,000 people. So, there's a sizable proportion of ethnic minority people that have been filling the survey. And in November of last year and January of this year, people in the survey were asked, how likely were they to take the COVID-19 vaccine if they were offered it. And we see here quite large ethnic differences, with the Black communities particularly being less likely to say that they will have the COVID-19 vaccine than the white communities. But by January 21, there's been a marked increase in the proportion saying they will have the COVID-19 vaccine. Still, that's a 30% gap in January between the white and Black communities. In terms of actually having had the COVID-19 vaccine, as the latest data that was available was January 21, so these figures are quite a bit out of date. So around 20% of people had the COVID-19 vaccine in the survey in January 21. And we don't see much of ethnic difference in in the survey. And actually, when you take account of the younger age of the ethnic minority populations, perhaps even slightly more ethnic minorities than the white population who report having had the vaccine. Now, this is the most interesting part of the survey. The respondents were giving reasons why they refused the vaccine, if they said they're unlikely to take the vaccine. So I categorized some of them into chances of, because of perceptions of risk, because people felt that catching the coronavirus was, the chances of getting the virus was low, or chances of becoming ill from the virus were low. And then a whole range of reasons that I categorize as misinformation, although maybe not, not quite so strong. So some of it could be herd immunity will protect me. Some of it because they're saying that the impacts of the virus is greatly exaggerated. Then a few reasons related to side effects, either currently or future effects. Clearly, one relating to trust, and a whole bunch of other reasons. And here again, we have the survey responses from November and January. And we see here the biggest reasons why people are given for refusing the vaccine was about worries about side effects. And we in November, there was sort of, you can see here, the South Asian groups were slightly more likely to be more worried about side effects than the white groups. And trust was a big issue, particularly for the Black groups. But in relation to misinformation or perceptions of risk, it's actually the white groups that had greater concerns about that than the ethnic minority groups. And by January 21, the picture largely remains the same, although some of the differences between the ethnic minority groups really disappears. So to summarize, ethnic differences in vaccine hesitancy are narrowing, although they're still quite large. So even though they're narrowing, they're still quite large. And it's unrelated to the perception of risk of coronavirus or related to misinformation. There's clearly some concerns about side effects, and trust in the vaccine is a key worry for Black communities. And I'm going to end with the most interesting question, which I can't really answer. What can be done? I can't answer that from the data that I have. I only have anecdotal experience from my friends who are in doing the sort of the vaccine rollouts, and they're saying that the community leaders, either religious leaders or GPs or GP practitioners who are part of ethnic minority communities, when they get involved in convincing their patients or fellow member communities to take part in the COVID-19 vaccine, that really does make a difference. So that really does sort of address that issue related to trust. So that's all that I have to say. Thank you very much for listening, and hopefully we have quite a few questions that you have listed. Apologies, I've just looked at the chat, and somebody said, "Could the speaker switch up his microphone?" I didn't see that in time. I'm sorry if you didn't hear me properly. I will try to speak up now. Now, if Alex and Ruth could switch on their microphones and cameras again, we have got a few questions for you. The first one is from Elizabeth Webb, asking about the gender difference and about the intersectional effects of sex and ethnicity. And does your analysis allow us to comment on the intersectional effects of sex and ethnicity on health?
Thanks, Elizabeth. Yeah, so I think you're right in your question. You've said that health tends to be worse for women compared to men in general, and that's absolutely true. But because each of our comparisons were between ethnic groups compared to the white British group, what we're showing is almost kind of a double disadvantage for women from ethnic minority backgrounds, because although in our analysis, we don't compare directly to men, but the starting point of white British women's health is worse than white British men's health. And then on top of that, the inequalities between ethnic groups for women are wider. So there are really substantial health disadvantages for women from a lot of ethnic minority groups. So yeah, by separating them out, we hope to be able to look at some of that intersection. But of course, if we were able to build in the full picture, we'd see those gaps even wider than as we presented. So thanks, yeah, that's an important point.
So there's a comment here from Emma about, from the beginning of the year, GPs are contractually obliged to record patient ethnicity in their records if the person chooses to share it. So ethnicity data should be getting better in Manchester anyways. Is that something that you can observe, Ruth, Alex?
Yeah, I mean, it's great. It's great that this is happening, and obviously, it takes a while for changes in administrative records to be fed through into data that we can access. But hopefully, this means that this is a first step in allowing ethnicity research in administrative health records.
There's a comment here from Rohina about the inequalities from my experiences have been actually since the 1980s. It's not just in later life, so it starts much earlier. Structural racism from cradle to grave. So yeah, so Alex, perhaps that's something that you'd like to comment on.
Yeah, so it's something that we highlighted in the discussion points. It's something that it's research that really needs to be done. Obviously, I'm not surprised that your experiences suggest that the inequality starts much younger in life. We were just really lucky with our data that we were able to get such a large sample, but that happened to cover the later age groups. If we had this similar data on such a large scale for younger population too, then that would be something that we would be really interested in testing. Ruth, I don't know if you had any other questions on that, any points?
Yeah, I think I agree, just to echo what you're saying. I think, yeah, you're absolutely right that, of course, there is evidence of substantial disadvantage across a lot of different domains, starting right from birth and through. I think what happens is that these disadvantages are happening and you begin to see these gaps in health outcomes appear, and then of course they widen as these disadvantages are just repeated and repeated. But we do need a kind of full life course approach to be able to really make progress on tackling these inequalities. We can't just look at the older adult population.
Yeah, and it's the recent study publicised yesterday about big ethnic inequalities in miscarriage rates and birth outcomes for children. So that is showing that is another opportunity of using a huge data set to be able to get at these questions. So that is really showing that it is cradle to grave inequality.
Yeah, there's another comment here from Rohina about language is not always a barrier, but it's the relationship of the ethnic minority people to the NHS or health professionals. So that's, I think, something that you document well, Alex, in your experience of healthcare services, isn't it?
Yeah, it is. Yeah. So apologies if I misspoke and suggesting that language was the sole and big driver. Hopefully, what came across is that we're calling for systems, all services, to be more culturally sensitive. It's not a one-size-fits-all approach. We need to adapt our services so that it differs by different ethnic minority groups to try and reduce these health inequalities, rather than just focus on something smaller, such as language.
There's a question here from Daniel about your reflections on accessing and using the GPPS. Was the recording of ethnicity good? Was it easy to access?
It's becoming increasingly difficult to access, is the GP patient survey. So it used to be quite easy to access it, but now it goes through. If you ever try to access hospital episode statistics, which is secondary care data sets, then it has to go through a protracted process with NHS Digital. The GP patient survey also now has to go through that process, so it is quite difficult to access. If you want to look at other things, though, is the GP patient survey. It is available aggregated to the GP practice level. So there's a lot of GP practices in the UK. So there's around, I think there's around 6,500 GP practices. So data is aggregated up to that level. Unfortunately, it's not broken down by ethnicity at that level. So there is an opportunity to use that data. using publicly available data, but you can't really answer ethnicity questions for that. But I'll let Ruth talk about reporting of ethnicity at the individual level.
Yeah, I guess just in terms of the data quality, it was about 10% missing, but it doesn't suffer from kind of those bigger issues of just kind of a lack of recording that happens in some administrative data sets. But where it's missing, it's people who have chosen not to report it in the tick box in the survey. So I guess there's perhaps a certain set of people who would rather not report it, and perhaps that comes down to those issues of trust and mistrust and wondering why data is going to be used that Alex was kind of alluding to. But for the majority of people, they do choose to share that information, so we're able to use it.
I'll take a final question from Mariella. It's a good one, but it's a big one. So in terms of possibilities for policy change, how might the Sewell report shape the political climate for this?
Yeah, that is a really good and huge question. I think obviously the Sewell report it's kind of astonishing that they could try and pitch that there is no problem. And I think it does seem like a massive step backwards in terms of trying to work towards equality. But I guess if you want to look for one aspect of hope, I think there has been such huge backlash to it. And there's been a lot of groups such as like the BMA and like very establishment groups, NHS figures and articles in the BMJ saying absolutely not. The NHS has to recognise that it has a problem. Public services have to recognise that they have a problem. And I think it's possible that we're moving into a period where there's going to be at least a lot more dialogue, and sure, there is clearly going to be more opposition from the government. They've made their position clear, but I think it has brought it much more to people's attention. And I think in the context of the COVID pandemic as well, there is some hope that there will be substantial backlash and that, for example, NHS services will begin to improve. Alex, I don't know if you want to add?
Yeah, I mean, just to echo your thoughts really, Ruth, yeah, it was a disappointing report. It made the age-old problem of controlling for socioeconomic status when comparing health across ethnic minority groups, which you shouldn't do because socioeconomic status is a determinant of health, and you shouldn't control for it. Like Ruth says, like there has been such a backlash to the report that you hope that that's filtered through into either the government's thoughts on it, but at least the public's perceptions of that report too. But as we all know, the first voice shouts loudest, and it might be hard to reel that back in, but fingers crossed it has helped that backlash. Brilliant.
Well, thank you, Alex, Ruth, and everybody for joining today. I'm just going to end with some plugs from advertisements for some future events. Those of you who might be interested in at Manchester, we have the Center on Dynamics of Ethnicity Code, and we have Professor James Nazru and Landry Malalu, talking about racial disparities in mental health care at the Stuart Hall Foundation on the 11th of May. We also have The Truth About Racial Inequalities in COVID-19. It's organized by The Conversation on the 4th of May. So please do get in touch, or I put in the links there if you're interested in that. Code will also be running the largest ever survey of ethnic and religious minority people. It's currently going on. You can sign up to that as well. So you can take part in the survey. It's called the Even Survey. And from MICRA, we've got a set of programs on the 27th of May on looking at digital dance. So not specifically about ethnic minorities, but looking about how older people have been coping with COVID-19 and digital platforms and physical activity. So thank you all very much for joining in. I hope to see you at one of our events later on. Take care. Bye-bye.
Thanks, everyone.
Yeah, thank you, everyone. Cheers.